Good morning, everybody. This is Patrick Hamilton with the Philadelphia Regional Office of the Centers for Medicare and Medicaid Services. I want to thank you for joining me this morning for the 2016 Medicare Quality Reporting Programs, What Eligible Professionals Need to Know in 2016. As I mentioned, my name is Patrick Hamilton, Health Insurance Specialist in the Philadelphia Regional Office. I'm joined in the room today by Dr. Barbara Connors, who is our Chief Medical Officer, and she will be helping me answer some questions at the end of our presentation. Before we get started, I just want everyone to know that the call is being recorded, and there will be a recording of the call made available 24 hours after the call. Also, we are in the process of producing a video version of this presentation, which will be posted on the MLN Connect's YouTube page, hopefully by the end of the month. We did the production on Friday. We're putting together the different modules, and we hope to have that ready to go by the end of the month. We will make sure that everybody who registered for the call has a link to the YouTube video once that is ready to go. Also, I sent out a copy of the PowerPoint presentation as a PDF file. So you need to have Adobe downloaded on your laptop in order to view the presentation. If you do not get a copy of it, first I would suggest that you check your spam or your junk email folder to see if it ended up there. And if you didn't get it, or if you signed up later this morning after I had your email address, then I'll make sure that you have it. I will give you my email address and Dr. Connor's email address at the end of the call. We have enabled a chat function, which should be on the lower right-hand side of your right-hand side of your screen. What we are going to do for the questions and answers, as questions come up, all of your phones are muted right now, but we're going to ask that if you have questions that are going to come up during the course of the presentation, that you can type them into the chat function. When Dr. Connors joins me, she will do her best to try to answer the questions as they come along. If we can't answer them, then we will try to address them at the end of the presentation during the Q&A session. There should also be a raise hand feature that is on the participants box. Once the question and answer session has started, we're going to ask that anybody who has a question just to click on the raised hand icon, and then Kimberly, our operator, will unmute your phone so that you can ask your question. The call is scheduled for 90 minutes. The presentation probably shouldn't take longer, hopefully, than 45 or 50 minutes. So hopefully we will be able to get to as many of your questions as possible. Kim, I just want to verify that you are able to hear me and that everything is okay with the audio on your end.
Yes, I can hear you. Some people aren't dialing in with the number. It hangs up on them, so the tech is working on it now.
Okay.
Thanks.
Thank you. All right, so we are going to go ahead and we're going to get started. So we have a lot of stuff to cover in the presentation today. As you can see, we've broken up this presentation into 6 sections. The bulk of the presentation is going to focus on the requirements for the 2016 payment programs, specifically PQRS, value modifier, and the meaningful use program. We'll also go into some information as to what will be made available in the Physician Compare both in 2016 and 2017. And we will start with a very high-level overview of the macro legislation that passed last year and will bring into fruition the new MIPS and APM incentive programs. So slide 4, we'll get started. The Medicare Access and CHIP Reauthorization Act, or MACRA, hopefully is a new acronym that you've heard, was passed by Congress last March, on March 26, 2015 to be specific, and President Obama signed it into law on April 16, 2015. 3 important changes come from MACRA as to how Medicare pays for those who give care to Medicare beneficiaries. First and foremost, and this is the thing that got the most headlines, it ended the Sustainable Growth Rate, or SGR formula, that determined Medicare payments for healthcare provider services. It makes a new framework for rewarding healthcare providers for giving better care and not just more care, so emphasizing quality over quantity. And also, it's combining our existing quality reporting programs into one system. So to that end, the separate payment adjustments currently being assessed under PQRS, the value modifier, and the meaningful use program, they all sunset as of December 31st, 2018. On January 1st, 2019, the incentive payments for the newly created Merit-Based Incentive Payment System, or MIPS, which is another acronym. If you have not heard yet, you'll be hearing a lot about MIPS, as well as alternative payment models, or APMs. They begin on January 1st, 2019. So Medicare-eligible professionals will be able to elect to take the MIPS track or the APM track in order to maximize these incentives. And for those who are going to be participating in the MIPS program, the payment adjustment could be positive, neutral, or negative, while an EP who elects to participate in an alternative payment model, or an APM, could receive an upward payment adjustment of 5%, actually a payment bonus, for up to 6 years if the criteria for that particular eligible APM are met. For those EPs who are electing to participate in the MIPS program, the incentives would apply to either individual EPs, groups of EPs, or virtual groups. For the first 2 years of MIPS, so for 2019 and 2020, the Medicare EPs that have been identified by the legislation as MIPS eligible are physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists as individuals. So if they're one of those 5 practitioner types and are solo, as well as any groups that have those specific types within them. And then starting in 2021, the law will give the Secretary discretion to add more eligible provider types, and any EPs participating in a qualifying or eligible APM would be excluded from MIPS, while those EPs who have been deemed as a partial qualifying APM participant will have the choice of either being exempt from MIPS or receiving the MIPS adjustment. The macro legislation also allows for certain low volume thresholds as well. And you should be aware of the fact that the proposed rule for what the specifics for MIPS and APMs will look like will be out sometime in the springtime, and CMS will be hitting the road very hard to make sure that you have all the information and are fully knowledgeable of what we're proposing for those programs. The stuff that's included in these slides are the parameters that were included in the legislation itself. So beginning in 2019, EPs who are participating in the MIPS program will be eligible for positive or negative Medicare payment adjustments that start at 4% and gradually increase to 9% through 2022. EPs will get a composite score that will range from 0 to 100 and will measure in 4 different categories, and there are the 4 categories that are listed at the top of the table. They are quality measures, resource use, clinical improvement activities, and meaningful use of certified electronic health record technology. The weight of each category starting in 2019 and going through 2022 is shown on the table of this slide. So for example, you'll see in the first year in 2019, 50% of your score, that will be from 0 to 100, will compose of the quality measures component. Resource use will be 10%, clinical improvement activities 15%, and EHR 25%. And then there's going to be some variation as we go through 2022. EPs who score at the threshold at the actual threshold will receive no payment adjustment upward or downward. Those whose composite score is above the performance threshold will receive a positive payment adjustment on each claim for the following year, while those whose composite score is below the performance threshold will receive a negative payment adjustment on each claim for the following year. And per the macro legislation, these adjustments must be budget neutral. Now, physicians who have high composite scores will be eligible for a positive payment adjustment that's up to 3 times the baseline positive payment adjustment for a given year. So, for example, you see that the baseline positive payment adjustment in 2019 is 4%. High performers will be eligible for a positive payment adjustment of up to 12%. So for 2019 through 2024, an additional positive payment adjustment of up to 10% will be available to exceptional performers. And then beginning in 2026, all physicians participating in MIPS will be eligible for a 0.25% increase in their payments each year. If you're eligible and choose to participate in a qualifying APM, you will receive a 5% lump sum bonus on your Medicare payments for 2019 through 2024. And then beginning in 2026, you'll qualify for a 0.75% increase in your payments each year. So we are still working through the proposals in terms of how we are going to define APMs and eligible APMs. The legislation itself defines any of the following as an alternative payment model. So it could be an innovative payment model expanded under the Innovation Center, the Center for Medicare, Medicaid Innovation, or CMMI, which includes the Comprehensive Primary Care Initiative participants, but not Healthcare Innovation Award recipients. It could also include Medicare Shared Savings Program, Accountable Care Organization, Medicare Healthcare Quality Demonstration Programs, or the Medicare Acute Care Episode Demonstration Program, or other demonstration programs that may be required by federal law. An APM must require participants to meet all the following criteria. So in order to be what's considered a qualifying participant in an eligible APM, the APM must use quality measures that are comparable to measures that are going to be developed under the MIPS program, that they use certified electronic health record or EHR technology, and bears more than a nominal financial risk, or is a medical home that's expanded under the Centers for Medicare and Medicaid Innovation. And as I mentioned, we're in the process of finalizing the proposed rules. The MIPS and the APM proposed rules will be released, I believe, as one combined rule. So look for that sometime this spring, and I would highly encourage that you take the opportunity to comment once the comment period opens for that. Moving on to the next section, we're going to go over briefly the incentive programs and the payment adjustments that are available for 2016 and 2018. And any of you who have been on the calls that we've had here for the past couple of years probably have seen these slides. These slides are gotten a little bit more complicated because of the way that some of the new non-physician practitioners are being brought into the program. The value modifier also is continuing a phased-in approach. So we're going to hopefully go through these slides. And we've done this presentation now a couple of times in front of audiences, and these slides, to look at them, look kind of complicated. When we get to the value modifier module and we do the animated decision trees that talk about how the value modifier is going to be applied in 2018, once you see those animated decision trees, it might make a little bit more sense to you, maybe a little bit clearer. So the charts, as I mentioned, they talk about the three programs that we are discussing: PQRS, Value Modifier, and the EHR Incentive Program. Before I move forward, Kim, if you could just send a message in the chat function to let people know that we're working on the audio portion. Let them know that that's hopefully going to be rectified shortly. Okay. So the next three slides are going to be the payment charts. The first one focuses on physicians. The green columns indicate potential incentives, and the red columns indicate potential payment adjustments. The payment adjustments would be assessed in 2018 because of the look-back period. Kim, I would also, I'm sorry, because I'm also getting emails. If you could also send a message in the chat function to make sure that their speakers are turned up. We used to do these telephone or these webinars over the phone line. So if people can make sure that their speakers are turned up, that might be an issue why they can't hear anything. Thank you. So let's start with PQRS. 2014 was the final year that we paid incentives for PQRS. Starting last year and for this year as well, if you're successful in reporting PQRS, then you avoid the 2% payment adjustment in 2018. Moving on to the value modifiers is where it gets a little bit trickier. The assessment of an upward, neutral, or downward adjustment or for physicians depends on the size of the group in which the physician practices, or if he or she is a solo practitioner. So for the first group, these are our physicians in groups of 2 to 9 EPs, and also for physicians who are solo practitioners. These physicians will be subject to an upward, neutral, or downward adjustment based on quality tiering for those who report for PQRS in 2016. Now, the upward adjustment, we'll explain that on a later slide, but the downward adjustment that these physicians could be assessed is either 1% or 2%. And we'll go into how the upward adjustment is calculated a little bit later. So based on quality tiering, if they are a physician in a group of 2 to 9 EPs or solo practitioners, They could get an upward payment adjustment, or they could be assessed a downward payment adjustment based on quality tiering. Now, for groups, physicians in groups of 10 or more EPs, the downward adjustment that could be assessed is either 2% or 4%. But regardless of the size of the group or solo status, if you are a non-reporter, if you're not doing PQRS, then it's an automatic downward adjustment. So it's 2% for the solo docs and the docs in the smaller groups. It's 4% automatic for groups, for the physicians in groups of 10 or more. That's in addition to the 2% payment adjustment for PQRS. Again, if you've been on these calls with me in the past couple of years, hopefully by this point you will understand the importance of reporting on PQRS. It's important to note that the incentives, there are still incentives available for meaningful use in 2016. 2016 is the final year that Medicare meaningful use incentives are available. So if you are a successful meaningful user in 2016, you can earn an incentive in the Medicare meaningful use program between $2,000 and $4,000, depending on when you actually started, depending on when your first year of meaningful use activity was. If you're participating in the Medicaid meaningful use program in 2016, your incentive could be $21,250. If you're starting this year with your Adopt, Implement, or Upgrade, or $8,500 if you are already along your way for meaningful use. So as you can see in the final column, it's critical that physicians, and again we're talking about physicians here, are doing PQRS and meaningful use in 2016 so that you can maximize the incentives that are still available, but just as importantly that you can avoid a total reduction in your reimbursement of 2018 of anywhere from 7 to 9%. As I mentioned earlier, CMS finalized a policy of including physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists for the assessment of the value modifier in 2018 based on your performance this year in PQRS. Originally, we had proposed that all of the non-physician practitioner types were going to be included in the value modifier, but because these 4 practitioners that are listed on this screen were included in the macro legislation for the first 2 years of MIPS, CMS decided just to include these specific practitioners, non-physician practitioners, for the value modifier. So this slide details how these 4 practitioners will fare under these programs during the 2016 performance year. As you can see, as with physicians, non-reporting of PQRS, that's that first column, will mean a 2% PQRS payment adjustment in 2018. For the value modifier, and this is where it gets really tricky, and again, this will make more sense hopefully when we do the animated decision trees. We will focus first on the PAs, NPs, CNSs, and CRNAs who are solo practitioners and who are working in groups that comprise only of non-physicians. So we're talking about these 4 practitioners if they're solo, or if they are working in a group, and it's in a group of any size that has no physicians in the group. That's what that first value modifier column indicates. Since 2018 is the first year for the assessment of the value modifier, if these particular EPs are PQRS reporters, so they're doing their PQRS reporting, then they would only be subject to an upward or neutral value modifier payment adjustment based on quality tiering, which means they're being held harmless to downward adjustment for poor performance. The amount of the upward adjustment would be a factor of 1x or 2x, and I'll explain that in a little bit later. Moving over to the next big chunk under the value modifier column, we're going to focus on physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists who are in groups, so they're in groups that have physicians also in the group. So again, this slide is specific to the 4 non-physician practitioner types, but who work in groups that have physicians in them. And the amount of the adjustment, upward or downward, depends on the size of those groups. So if the size of the group is 2 to 9 EPs, and if they're PQRS reporters, they can be subject to an upward, neutral, or downward adjustment based on quality tiering. And the amount of the upward adjustment could be a factor of 1x or 2x, and the downward adjustment could be 1% or 2%. Now, moving over to the second half of that column, for the groups that comprise of 10 or more EPs, the amount of the upward adjustment would be a factor of 2x or 4x. The downward adjustment could be 2% or 4%. That's because groups of this size, 10 or more EPs, have been assessed the value modifier for a number of years now. So their upward and downward adjustments are increased accordingly. And again, regardless of the size of the group, if anyone does not report PQRS, then there's an automatic downward payment adjustment of either 2% or 4%, depending on where you fall on the chart. Now, these practitioners are not eligible for the Medicare Meaningful Use Program, so they're not subject to any Medicare Meaningful Use payment adjustments. However, the physician assistants and nurse practitioners, if they meet the requirements of the Medicaid Meaningful Use Program, they can still earn incentives. So and by the way, there are no payment adjustments for Medicaid. So just that's a note. So the final column shows that for these 4 practitioner types who don't report PQRS, they could be facing a total downward adjustment of 2 to 6% for 2018. Our final slide in this module shows the same programs and how they will affect reimbursement for non-physician practitioners who are not PAs, NPs, CNSs, or CRNAs. As for PQRS, again, subject to a 2% payment adjustment if you're not reporting. For the value modifier, these non-physician EPs will not be subject to the value modifier in 2018. So if you are one of these practitioner types or work in a practice that does, these particular EPs will not be subject to the value modifier. So as you can see in the final column, the total Medicare payment at risk for non-reporting is 2%. Okay, we are now going to move on to PQRS, and I'll say from the upfront that there weren't too many structural changes with PQRS in 2016 in terms of the reporting requirements, the mechanisms that you can use to report. So I'm going to go through this rather quickly. There are a number of decision trees, and I've put them in the presentation so that you'll have them for your reference, but you're going to see that there is some repetition, especially when we talk about, for example, the requirements to report for individuals versus group using a qualified registry or using an EHR. There's a lot of repetition. So I'm going to go through some of the decision trees a little bit more quickly than I will for others. But I wanted to make sure that you have that information available to you. So the changes that did take place in the PQRS program for 2016 were done through the regular annual rulemaking process. So that's when the 2016 Medicare Physician Fee Schedule rule, we have a proposal that comes out in the summertime, we receive comments, and then we finalize it, and then changes to those programs are made through that process. The proposed rule went on display on July 15th of last year, 60-day comment period, and the final was placed on display at the Federal Register on October 30th. There are a total of 281 measures in PQRS, including 23 cross-cutting measures and 18 measures that are included in the Group Practice Reporting Option, or GPRO, web interface. For those that are using Registry Reporting Option and Reporting Measures groups, there are 3 new measures groups that have been developed. They are multiple chronic conditions, cardiovascular prevention in conjunction with the Million Hearts Initiative, and diabetic retinopathy. One of the big changes to PQRS this year, and this was actually part of the MACRA legislation, the Qualified Clinical Data Reporting Option, or QCDR. Previously, that was only available to individual EP reporters. MACRA now allows groups to elect the QCDR reporting option, and we'll explain how that would be done when we go into the GPRO reporting option. And as I mentioned previously, 2018 is the final year that the payment adjustments for the value modifier will be assessed in advance of the MIPS and the APM programs. So what I'm going to do is just go through each of the reporting options. We'll start with claims. We'll start with the individual EPs, and then we'll go into GPRO. And again, you're going to see that there's going to be a lot of repetition. So for individual EPs who choose to use the claims reporting option. And this is the same as last year. The requirement is to choose 9 measures that come from at least 3 of the 6 national quality strategy domains. And those domains include patient safety, person and caregiver-centered experience and outcomes, communication and care coordination, effective clinical care, community and population health, and efficiency and cost reduction. The requirement to report on at least 1 cross-cutting measure remains in place in 2016, and the cross-cutting measures must be reported if the EP has at least 1 face-to-face encounter with a Medicare beneficiary. Those face-to-face encounters are identified by billable codes and generally include things such as office visits, outpatient visits, some surgical procedures. Telehealth claims are not included. They do not meet the definition of face-to-face encounters. And again, in the instance if an EP can't choose 9 measures from at least 3 of the quality domains, then we have an measures applicability validation process for EPs who report less than 9 measures or who choose from less than the 3 quality domains to verify that is in fact the case, that they were not able to choose additional claims. So this is actually, quite easy. So for those who are reporting on claims, the measures type, you can choose individual measures. And again, you want to make sure that you are aware that we have 281 measures, but not all 281 measures can be reported using all of the different reporting options. So if you are going to use the claims reporting option, make sure that the measures that you are choosing can be reported via claims. And as I mentioned, the requirement is 9 measures from 3 domains, and if you can do that, then that is what you will report. However, if you can't find 9 measures covering at least 3 domains, then we'll allow you to choose less than 9 measures covering 1, 2, or 3 of the domains. You'd be subject to the validation process. And again, the requirement to face-to-face encounter, at least 50% of your Medicare Part B fee-for-service patients must be reported on. And any measure that has a 0 performance rate, you would not count. So you would just choose another measure. Now, in terms of those cross-cutting measures, I've included those on the next 4 slides. If an EP, as I mentioned, has a face-to-face encounter with a Medicare Part B fee-for-service patient during the reporting period, cross-cutting measures are taken from each of the 6 quality domains. So I list the domain and the measure title, and then also the mechanism by which they can be reported. An updated list of the codes that are considered face-to-face encounters, I mentioned that they're identified by billable codes, can be found on the PQRS page of the CMS website by clicking on Measures Code, which is on the left-hand side of the page, and you scroll down to the section that is titled 2016 Cross-Cutting Measures Requirement. So moving on to the qualified registry. It's another way that individuals and groups can report PQRS measures in 2016. And also, it's the only method that individual EPs who want to use measures groups, want to choose a measures groups, can actually do so. You can only use the registry to report a measures group, and that option is only available to individual EPs. There's also the requirement of reporting on at least 1 cross-cutting measure if there's at least 1 face-to-face encounter with a Medicare patient, as previously discussed. Registries who qualify, who self-nominated by January 31st and have been accepted into the program now have the capability of using the web to attest to the accuracy of quality measures and all associated data instead of doing a written attestation. So for individual EPs who are using a qualified registry, what types of measures are going to be reported on? If you're going to use individual measures, then you can report at least 9 measures from 3 domains, and if you can do that, that's what you report. If you can't find 9 measures from at least 3 domains, then you can report 1 to 8 measures from 1 to 3 of the domains. As with the claims option, in either case, if there is at least 1 face-to-face encounter, you report on 1 cross-cutting measure, and the same 50% rule applies, as we mentioned before. If you're able to report on one of the measures groups, and that's the route you want to go, then you may select one of the measures groups, which are listed on the next slide, and you report each measure contained within that group for at least 20 patients. And then of your 20 patients or more, if you choose to do so, a majority of those patients must be Medicare Part B fee-for-service patients. And any measure with a 0 performance rate would not be counted. So for Medicare Part B fee-for-service patients, if you're going to do a sample size of 20, for example, then you have to choose 11, since that would be a majority. And again, Medicare Advantage patients do not count in this calculation. Here are the 25 measures groups that are available for registered reporting this year. Each group has at least 6 associated measures that are related to a particular condition. So if an EP chooses a measures group, then all the measures that are included within that group must be reported at least once for all patients included in the sample. And we have specification documents for all of the groups, which can be found on the measures code section of the PQRS page on our website. Also, we've been working with our specialty societies to find appropriate measures for PQRS reporting that pertain to specialty scopes of practice. We started that this year. The 12 that are listed on the top half of the slide were ones that were included last year. We added 5 additional specialty measure sets in 2016. These are by no ways required measures that, for example, a pathologist would have to report, but it's just a recommendation. We get a lot of inquiries into the regional office asking us for help to find measures for specific specialties. So to that end, specialty measure sets have been developed. Our next decision tree gives over the requirements for individuals who choose to report using a certified EHR or a data submission vendor. The measure type that would be reported are individual measures, and the requirement, again, is to report 9 measures from at least 3 of the quality domains. Now, if your certified system or if your submission vendor that's used by the EP does
is there a limit to the number of calls that would be displayed on the monitor?
Kim, I was disconnected. Can you let me know if I'm back on?
Yes, you're back in.
All right.
I can hear you now.
Okay, sorry about that, folks. So we're on slide 24. We're just reviewing the requirements for the EHR data submission vendor option for reporting for PQRS. It's 9 measures from 3 quality domains. And I was saying that if your system does not have 9 measures from 3 domains, then you would report on all of the measures for which there's Medicare patient data. So keep in mind that an EP certified EHR will include data that has data for your entire patient population, not just Medicare. So EPs must report on at least 1 measure that has Medicare patient data. EPs who want to use a QCDR or Qualified Clinical Data Registry in 2016 will have the opportunity to report on both PQRS measures and non-PQRS measures, which could be up to 30 that are included to be reported in a QCDR. And a QCDR that is approved by CMS to participate in PQRS will have at least 9 measures that cover at least 3 of the quality domains. So QCDR applies to be in the PQRS program, and CMS will ensure that all of the QCDRs that are included have the minimum requirements, so that if you do opt to use that particular option, a particular QCDR, that you will be able to meet the requirements. If you choose to use a QCDR, you must report on at least 2 outcome measures as part of the quality codes that you're submitting. Now, if there are less than 2 outcome measures available to report, then the EP would report 1 outcome measure and 1 additional measure from either 4 of the other domains, those being patient safety, resource use, the patient experience of care, or efficiency, appropriate use, quality domains. And more info about the outcome measures can be found in the PQRS implementation guide on the PQRS page of the CMS website. So now we're going to move on to GPRO, or the Group Practice Reporting option in 2016. Group practices that wish to participate in the GPRO must register in the PQRS system between April 1st and June 30th of 2016. And this is something that sometimes gets overlooked, especially if you are wanting to do the GPRO web interface, or if you want to do any of the requirements or any of the reporting mechanisms that are available under GPRO. You have to register no later than June 30th of 2016. Now, keep in mind, there's no requirement that groups have to participate in GPRO, but if you do have the capability to find measures that are applicable to all of your providers in the practice, you're encouraged to do so. The size of the group, which is the total number of eligible professionals under the tax identification number or TIN of the group, will determine what voting or what reporting mechanisms or methods are available for reporting purposes. For example, only groups of 25 or more EPs can use the GPRO web interface. Also continue in 2016, groups that register for GPRO that have more than 100 EPs will be required to submit patient survey data via the Consumer Assessment of Healthcare Providers and Systems, or the CAP survey. I'm going to go into detail about how those reporting requirements spell out in 2016. However, we do know that there are going to be some group practices or 100 or more EPs that may not have a sufficient number of beneficiaries to produce reliable data, so they will not be able to report the CAP survey. And so you'll be notified if you will be exempt from the CAP survey. And as I mentioned, groups now have the option of using the QCDR method of reporting that only previously have been available to individuals. So I'm going to go through quickly the reporting options. And again, you're going to see there's a lot of repetition, so there's not going to be a whole lot of reason to pontificate on this in too much detail. This is the requirement for groups of 2 to 99 EPs, and also for groups of 100 or more that CAPS does not apply. So I just mentioned that there are going to be groups of more than 100 who otherwise would be required to report on CAPS, but there may be some instances where you won't be able to. So if you're using the registry, it's the same requirement that we just went through for the individuals. 9 measures, 3 domains. Report on less. If you can't, you'd be subject to the validation process. Same thing with EHR. So this applies to groups of 100 or less EPs or 100 or more EPs if CAPS does not apply. And I'll explain why there's the distinction, because if the CAP survey does apply to your group of 100 or more, the reporting requirements are a little bit different. But again, the same requirement as for individuals. For the GPRO web interface, only groups of 25 or more EPs that register for GPRO can use the web interface to submit quality data in 2016. We're maintaining that the beneficiary sample size is set at 248. If you do not have 248 patients, then you would use 100% of all the patients that are attributed. And if the group doesn't have any Medicare patients for any of the measures, which there are 18 in all, then you should choose a different reporting mechanism. So for the GPRO web interface, this is for all groups of 25 or more that choose the interface. You report on all the measures that are included, and then you populate the data fields for the first 248 consecutively ranked and assigned beneficiaries in the order in which they appear. And if you don't have 248, then you report on 100% of your assigned bennies. The next 2 slides show what the individual measures, the 18 measures, that have been finalized for GPRO web interface in 2016. And again, keep in mind that if you choose the GPRO web interface reporting mechanism, you have to be able to report on all 18 measures that are on these 2 slides. As I mentioned earlier, Section 101 D1B of MACRA allows for groups to now choose the QCDR reporting option. And the reporting period is the same as for individuals. It's a full 12 months. And the same criteria in terms of what must be reported via the QCDR are in place. So this is going to look very familiar. It's the individual and PQRS measures and non-PQRS measures must report 9 measures from 3 domains, and then 2 outcome measures If you don't have an outcome measure, then it's one outcome measure and then an additional measure that's listed there. So the CAPS for PQRS survey is required for groups of 100 or more EPs. It's an optional reporting method for smaller groups. So again, mandatory for groups of 100 or more EPs. Groups of less than 100 or more, or less than 100 EPs that want to use the CAPS for PQRS survey may do so. Regardless of the group size, groups who are using the CAPS for PQRS survey will be required to contract with a certified vendor who will collect the survey data and submit that data to CMS on behalf of the group. So starting last year, groups will be responsible for the cost of administrating that survey, and that continues this year. And the measures that are included in the 2015 are the same measures that were included last year, and they are listed here on slide 36. So, as I mentioned, the reporting requirements for those who are either required to submit the CAPS for PQRS or for those groups who choose to do this as an optional reporting method. You would report on the 12 points that were on the previous slide. And then you have to do so in conjunction with one of the other reporting methods for submission of additional quality measures. So you would do, for example, the 12 CAPS for PQRS survey measures, and then you could choose the qualified registry, for example. And if so, then you report on at least 6 additional measures which are outside of the CAPS, covering at least 2 of the domains. You see the requirement in terms of the registry goes down a little bit because you're submitting the patient survey data. If the group chooses the registry but can't report on at least 6 measures from at least 2 domains, then we go through the validation process. You can report up to 5 measures, and we have to make sure that a cross-cutting measure is included. Now for the G-Pro web interface, it's still the entire all 18 measures. So you'll be reporting the patient survey data plus everything that's in the web interface. So there's no reduction in the requirement if you're using the web interface. For EHR reporting, you would report on at least 6 additional measures from at least 2 of the NGS domains. We'll also go through the validation process if 6 measures don't apply to the group. And again, the same requirement with reporting at least 1 measure for which there's Medicare patient data would be present here. And then for QCDR, you report on at least 6 measures from 2 of the domains. So that is it for PQRS. We're now going to move over to the value modifier policies, and this is where it gets a little interesting in that the continued application or the phasing in of additional providers under the value modifier continues in 2016. And again, I'm going to do my best to try to walk through the policy for 2018. Again, it's based on the 2016 performance. This is the performance year for 2018. We had taken a phased-in approach in phasing in physicians. They were the first group of Medicare EPs that were phased in. The actual application of the value modifier started for some physicians in 2015 based on 2013 PQRS activity. And as with last year's value modifier, quality tiering is mandatory in 2018. However, for PAs, NPs, CNSs, CRNAs, they are the 4 non-physician practitioners who were brought on board this year, who are either solo practicing or in groups identified by its TIN that contain only non-physicians. And we're going to go back to that distinction between groups that have physicians and do not have physicians. That's going to be an important distinction. So just beware of that. All physicians, both solo and those are in groups and the 4 practitioner types mentioned above, in groups of 2 or more EPs that include physicians, will be subject to upward, neutral, or downward value modifier adjustments based on tiering, quality tiering. And again, the caveat here is that if you're not reporting on PQRS, then it's automatic downward adjustments in addition to the PQRS adjustments. And again, 2018 is the final year for the value modifier because we'll be moving into MIPS and APMs starting in 2019. So for those of you who are not familiar with what the value modifier is, it is a modifier to physician fee-for-service reimbursement for Medicare Part B services that takes into account the quality of care that you provide to your patients and the cost of that care. So to that end, there are quality measures that we look at, and there are cost measures that we look at. So the quality measures is the first thing we're going to focus on. And the measures that we use to calculate the quality portion of your value modifier score comes from a combination of PQRS performance, and then also outcome measures that are analyzed by claims data, and if applicable, the CAPS or survey. So we went into a lot of detail about the PQRS portion of the quality score module in the last section, so we won't go through that. So the big takeaway, if you're new to value modifier, if you're hearing about this stuff for the first time, you may be thinking to yourself, what else do I have to submit to CMS in order to do the value modifier or to be assessed fairly under the value modifier? You have no additional reporting requirements other than PQRS. When we're talking about these outcome-based measures, they're all claims-based, which means CMS will analyze the claims as it relates to the three things that you see here: all-cause hospital readmissions, the composite for preventable hospitalizations for acute conditions, and also for chronic conditions. And then the CAPS measures, again, that is in conjunction with what you are reporting to CMS. Excuse me. Now, in terms of the acute prevention quality indicators, they include bacterial pneumonia, urinary tract infection, and dehydration. And for the chronic prevention quality indicators, they are COPD, heart failure, and diabetes. In terms of the cost measures, these are the same measures that are used in previous years. So they are a total per capita cost measure, which are the annual payment standardized and risk-adjusted Part A and Part B costs. The total per capita cost for beneficiaries with 4 chronic conditions that have been identified and listed on this slide, those being COPD, heart failure, coronary artery disease, and diabetes, as well as the Medicare spending per beneficiary for all A and B costs that occur 3 days before and 30 days after an inpatient Medicare stay in the hospital. All right, so these next 3 slides, these are the payment tables, or these are the tables that show the upward or downward or neutral adjustments based on quality tiering. So the way that the value modifier works is that you are categorized on both quality and cost as either being low, average, or high. So as you can see, it's a 3x3 schematic, so there are 9 possible boxes that you could fall into. And the amounts of the upward and downward adjustments are going to depend on a number of things, and we touched on this when we looked at those red and green charts. So I'm going to go into a little bit more detail here in the next 3 slides, and then hopefully when we go to those animated decision trees that I'm promising, it'll make even more sense, or at least a little bit more sense. So this first table, these are the upward and downward adjustments in 2018 for physicians, PAs, NPs, CNSs, and CRNAs who are in groups of 10 or more EPs that include physicians. So again, we're looking at groups that have 10 or more eligible professionals. And when we say 10 or more EPs, those are all the different Medicare EP types. So not only the 5 that are listed here, but the size of the group to come up with 10 or more also include people like your audiologist, your speech pathologist, all of those EPs. That determines the size of the group. But for this particular table, we're looking at groups that have physicians within them, okay? These groups are subject to quality tiering that could yield upward, neutral, or downward adjustments for the value modifier. Based on their performance in the quality and cost measures, these groups could receive a downward adjustment of 2 or 4%, and you'll see that under low quality, or an upward adjustment of a factor of 2x or 4x. And again, for these folks, there is an automatic value modifier downward adjustment for 4% if they just skip PQRS altogether. So we indicate what the exact negative adjustments are in this table. That's the 2%, the 4%, but not exactly what the upward percentages are because of the requirement that this is all budget neutral. So we have to calculate how much money we have available to give for the upward adjustments. So in order to ensure that budget neutrality, we first calculate the total amount of the downward payment adjustments that will be applied, which includes the automatic cuts or downward adjustments for those who are non-PQRS reporters, and also for those that fall under the low quality or the average quality and high cost. So we will figure out how much is reduced from the downward payment adjustment, and then using the total downward, the amount, we'll then solve for the upward payment adjustment for the factor X, and then we apply accordingly. So basically, it turns out to be just a complicated algebra equation. So we're taking from the downward adjustment, we're figuring out how many practices or how many practitioners qualify for one of the upward quality adjustments. We divide it, we solve for X, and then we apply the upward adjustment factors. Additionally, if a group's average beneficiary risk score is in the top 25%, they could be eligible for an upward adjustment factor of 1. And that information, by the way, would be included in your QRUR report that you hopefully have been accessing. Now, this next slide, the table on the next slide, deals with physicians, PA. So it's the same idea. It's these 5 practitioner types who are in groups. They're smaller groups. They're 2 to 9 EPs. The groups have a physician in them. And we're also talking about solo physicians. So again, for this particular table, we're talking about physicians, PAs, NPs, CNSs, and CRNAs who are in groups of 2 to 9 EPs. Within those groups, there is at least one physician. And in addition, we're also talking about solo doctors, solo physicians here. So the cost and quality categories are the same for these groups and for solo physician practitioners. But as you can see from the chart, practitioners in these groups can see a reduction of 1 or 2% downward, but conversely can see an upward adjustment factor of 1x or 2x based on their scoring. So it's the same idea. It's just the amount of the adjustments are slightly lower for these smaller groups and for solo physicians. Now, this last table deals with specifically PAs, NPs, CNSs, and CRNAs who are solo. So they have a solo practice, they're one of their 4 types. Or they're working in a group. The group can be of any size, but the group has no physicians in it whatsoever. So as we mentioned, these practitioners are not subject to the downward payment adjustment based on quality tiering, which is why you see zeros in that first column. So long as they are reporting their PQRS and are successful reporters, they won't be dinged in 2018 if they would have otherwise fallen into the low quality average cost or low quality high cost. They're held harmless because this is the first year for which these particular providers will have been assessed the value modifier. 2016 is the second performance year for individual EPs and groups who are participating in the shared savings program. For those EPs, the cost composite will be given a score of average, similar to last year. Well, this year, the quality composite will be based on quality data that is submitted by the EP or the group per the requirements of the shared savings program, as well as quality data from the CAPS for ACO survey. So there's a CAPS for PQRS survey, there's also a CAPS for ACO survey. Now, if the ACO does not successfully report on the required quality measures per the shared savings program, then the groups or the individual EPs would be subject to the applicable automatic downward value modifier adjustment, and it would be the same, either the 2% or 4% based on the size of the group. For solo physicians and physician groups in which at least one EP is participating in the Pioneer ACO model or the Comprehensive Primary Care Initiative or some other similar Innovation Center model in 2016, they will have the 2018 value modifier waived. CMS will make this determination if at least one EP bills under the TIN of a group that is participating in one of the programs listed on this slide. All right, so now we are going to go through the decision trees for So now we're going to go into the decision trees for how PQRS participation will affect the value modifier in 2018. And we're going to do this in two different slides, and hopefully, I'm sorry, Kim, if it's possible, can you make Barbara Connors okay, I'm sorry, never mind. We're having some technical issues here in the regional office, but that's okay. Okay. Sorry about that. So we are going to go through two decision trees. And again, hopefully if you have been thoroughly confused in what I've been talking about so far, hopefully this will help make it a little bit more clear. So we're going to start with those EPs or groups who decide not to do PQRS. And hopefully at this point you understand the importance why you need to do so. And if you haven't, then hopefully this will tell you why you should not choose this path. So if you are deciding that you're not going to report PQRS, the first thing we need to ask or to determine is if you are a physician, a PA, NP, CNS, or CRNA. If you are not one of those provider types, then because you're not doing PQRS, you will not be, or you will be subject to the PQRS payment adjustment at 2%. But because the value modifier doesn't apply to the providers who aren't one of those five, then they would just get the 2% payment adjustment. So again, not reporting PQRS, and you are not a physician, PA, NP, CNS, RNA. It's a 2% PQRS payment adjustment. If you are one of those five practitioner types, then we would ask, are you solo or are you part of a group? And if you are solo, then it's the 2% value modifier downward adjustment, and it's the 2% PQRS payment adjustment for a total of 4%. If you are part of a group, and again, I have stated repeatedly that we have to make the determination if there are physicians in the group, because that will determine what the amount of the adjustment would be. If there are only non-physicians in the group, so no doctors in the group, then for these folks, it's the same downward adjustments that we mentioned, 2% for PQRS, 2% for value modifier. If there are physicians in the group, then we have to determine the size. If there are 2 to 9 EPs in the group, the same adjustments apply. If there are 10 or more EPs, then it's the 4% automatic adjustment and 2% for PQRS. The next tree that we're going to go through, and hopefully this is the decision tree that you all will be walking through because you will be reporting on PQRS. Again, we will have to identify or determine if you are a physician, PA, NP, CNS, or CRNA. And if you're not, then again, because you are reporting, you avoid the PQRS penalty. And again, the value modifier doesn't apply to you because you're not one of those provider types. If you are, so you're a reporter in 2016, you're a physician, PA, NP, CNS, CRNA, we ask if you are solo. And are you a solo physician? So for the solo physician who is reporting, you're avoiding the PQRS penalty, but because you're a physician, then based on quality tiering, you could get the upward, downward, or neutral value modifier. It can be anywhere from a negative 2% to a factor of 2.0x. Again, it's for solo physicians. Now, for the solo PAs, NPs, CNSs, and CRNAs, if you are reporting, then you avoid the 2018 PQRS payment adjustment. But again, you are held harmless from downward adjustment for poor performance, which means you could either get an upward or neutral value modifier adjustment from anywhere 0% to an upward factor of 2.0x. Now, if you're one of these provider types and you're practicing in a group, and by group, that means you've either registered for the GPRO reporting option or you meet the 50% threshold option. And what that means is that you don't register the group for the GPRO, but at least 50% of the individual EPs under the TIN of the group are successful PQRS reporters. And again, we go back to the question if there are physicians in the group. And if there are no physicians in the group, then again, they are held harmless from downward adjustment, so they avoid the PQRS penalty, and they could get an upward or neutral value modifier. If there are physicians in the group, then again, based on the size of the group, for the smaller groups, the 2 to 9 EPs, they avoid PQRS, and they would be subject to upward, neutral, or downward value modifier adjustments anywhere from negative 2% to a positive 2.0x. And for the groups of 10 or more EPs, they avoid the PQRS payment adjustment, and they will be subject to quality tiering anywhere from 4% downward to an upwards adjustment factor of 4.0x. The next 5 slides are here just for your reference. They give an overview of the value modifier policies for 2016 through 2018. So I'm not going, in the interest of time, I'm not going to speak on those. These were taken from the national call that was done in December by the Medicare Learning Network. So if you have any questions about that, feel free to send them to me after the call. And this slide gives you a very good, concise, step-by-step action plan for 2016 that you and your practice should be following to make sure that not only are you reporting on PQRS, but you're also obtaining your QRUR report, which is basically your quality report card. A lot of information is available to that, and also if you detect that there is an error in any calculation on either the quality or the cost stuff that's in your QRUR report, you have 60 days from the date of release, and they are usually made available sometime in the September timeframe. And we heavily advertise when those are out, so please be paying attention and make sure that you go in and report or that you get your reports when they're made available to you. I'm quickly going to go over the physician compare updates for 2016. We'll continue the phased approach to public reporting by publishing 2016 data for individuals, groups, and ACOs. The following quality data is available for public reporting. This is going to happen late next year, late 2017. All 2016 individual EP and group practice PQRS measures, so everything that's reported via PQRS. The caps for PQRS measures for groups of 2 or more EPs who meet specified sample size requirements and who collect the data via a CMS-specified certified CAPS vendor. And then also for anyone in the ACO, all ACO measures, including the CAPS survey that is administered in the ACO program. In addition, the physician compare will include an indicator on profile pages for individual EPs to satisfactorily report on the 2016 PQRS cardiovascular prevention measures group in support of the Million Hearts Initiative. Also, all individual and group level QCDR measures, including the PQRS and the non-PQRS measures, are going to be available for reporting late next year. We also plan to report an item-level benchmark for group practice and individual EP PQRS measures using the Achievable Benchmark of Care, or ABC methodology that you might have heard of, late next year. And this benchmark is going to be stratified by reporting mechanism, so depending on how you report, to ensure that we're comparing apples to apples and to reduce the interpretation burden on your behalf. Consistent with existing policies, all data must meet the public reporting standards, which means that any measure designated as available for public reported may be included on the physician Physician Compare website. However, CMS will decide which measures to publicly report based on a number of factors. All of the measures on Physician Compare must be statistically accurate, valid, reliable, and comparable, and must resonate with, with consumers. Physician Compare also uses the downloadable database for information that is geared toward healthcare professionals, industry analysts, and researchers who are familiar with more complex data. Adding information to the downloadable database ensures that the Physician Compare profile pages remain consumer-focused while providing useful information to the healthcare industry, researchers, and other stakeholders. So the Physician Compare will add some utilization and value modifier data to the downloadable database. Under MACRA, Physician Compare is required to publicly report utilization data. So we'll report utilization data in the downloadable database rather than the consumer-focused website profile pages. Not all of the available data will be included in the downloadable database. The specific HCPCS codes included will be determined based on analysis of the available data focusing on the most used codes. Physician Compare also plans to add the following 2016 value modifier information to the database in 2018. Quality tiers for cost and quality, noting if the group practice is high, low, or neutral. A notation of the payment adjustment received based on the quality and cost tiers. And an indication if the individual EP or the group practice was eligible to but did not participate or report quality measures to CMS. All right, moving into the home stretch, I'm going to give a brief overview of meaningful use for 2016. There was a final rule that included the EHR incentive programs in 2015 through 2017 that made many significant changes to the program in order to help providers meet program requirements. You may have heard this as the modifications rule. Chief among these changes was the alignment of objectives of measures from both Stage 1 and Stage 2 into one set of objectives. In doing so, CMS eliminated several measures that were duplicative or topped out, which means that measures achieve widespread adoption at a high rate of performance and no longer represent a basis upon which provider performance may be differentiated. Some of these individual measures that have been removed include recording vital signs, demographics, smoking status, sending patient reminders, image results, et cetera, et cetera. Starting in 2015, the EHR reporting period for all providers is based on the calendar year, which means we're moving the eligible hospitals and critical eligible hospitals from a fiscal year reporting period to a calendar year reporting period. Starting in 2016, eligible hospitals and critical access hospitals report on the calendar year, as I just mentioned. And the final rule also made important modifications to the two objectives that require patient activity. And I'll go into a little bit more detail in a few slides. That's the patient electronic access or review, download, and transmit, and secure messaging. CQM reporting has not been changed, so the methods or the means by which you are reporting your CQMs for meaningful use did not change based on the modifications rule. For this year, the reporting period for all participants who are returning to the program is a calendar year, so your reporting period runs from January 1st through December 31st of 2016. So eligible professionals, hospitals, and CAUs that are new participants. So if this is your new year, you're starting just in 2016, then you have any continuous 90-day period between January 1st and December 31st. The final rule from last year also gives specific alternative exclusions for measures 2 and 3 of the CPOE objective for any providers who were scheduled to be in Stage 1. So you would have been in Stage 1 in 2016 if this would have been your first year or if last year was your first year. Eligible hospitals and CAUs also have an alternative exclusion for Objective 4, which is the e-prescribing, if they were scheduled to demonstrate Stage 1 this year, or were going to be in Stage 2 but was not going to select that as an optional method, or an optional, objective. So I've included in the next couple of slides, after this slide, all 10 of the objectives, but I'm not going to go through them. They're for your reference. But what I want to highlight are the patient engagement measures. And as I mentioned, those were the two critical changes for 2016. So they are Objective 8, patient electronic access, and then measure 9, objective 9, which is secure messaging. The patient electronic access measure 2, which previously stated more than 5% of all unique patients seen by the EP during the EHR reporting period, or on the hospital side, are discharged from the inpatient or emergency department of an eligible hospital or critical access hospital, that they had to either view, download, or transmit to a third party their health information. And that was in stage 2. So for 2016, the requirement is no longer 5%. It is just one patient seen by the EP during the reporting period, or who is discharged from the hospital, the inpatient or emergency department, must either view, download, or transmit. Now, in 2017, the measure threshold reverts back to the 5% threshold. So this year, only one patient, but I would strongly suggest that you use 2016 to engage your patients in how they do their viewing, downloading, or transmitting of their information. In terms of the secure messaging, and this is only for EPs, the hospitals are not required to do secure messaging. The previous stage 2 measure said that a secure message was sent using the electronic messaging function of CERT by more than 5% of unique patients. The final rule from last year, again, the measure threshold was lowered in 2016 to require that for at least one patient seen by the EP during the calendar year, a secure message was sent using the electronic messaging function of the CERT to the patient, or in response to a secure message sent by the patient during the reporting period. And again, note that for 2017, as with the patient electronic access objective, the measure for secure messaging also reverts to a threshold of more than 5%. So as I mentioned, the next couple of slides have all of the objectives. I'm not going to go through all of them. You can look at the information. So what I did here is I listed the objective as it pertains to EPs, and if there are any hospitals or critical access hospitals on the calls. There are some differences on some of the objectives, both on what the objective is itself, the measure specific for 2016, and then also exclusions, because certain criteria must be met for certain objectives in order to qualify for an exclusion and still be deemed a meaningful user for this year. And as I mentioned earlier, the reporting, the CQM portion of meaningful use has not changed. So there are all the phone numbers. If you have questions for the mechanics of any of these programs, if you have questions with registration, data submission, anything like that, your first line of defense, or your first line of contact actually would be the help desks that are listed on this slide. And again, if you don't have a copy of this presentation, I'll be happy to share it with you. And then just some of the resources that are available, very difficult to read, but in the slide deck that you get, the links, I believe, should work. If you have any questions that we are not able to answer during the presentation, you can send an email directly to myself. My email address is patrick.hamilton, Hamilton, @cms.hhs.gov.
Can we take a few questions?
Yes.
Okay.
All right. With that, we are going to, and Kim, if you could help facilitate this, we're going to attempt, and I am a little nervous because we've been having some issues with the phones, it seems. What we're going to do is we are going to ask if you have a message or if you have a question to raise your hand or to click on the hand icon underneath the participants list. And then Kim will unmute the phone of the callers that have questions in the order in which the hands were raised. Is that correct, Kim?
Yes, that's correct.
Okay. It is now, we have about 17 minutes or so, so we are going to do as many questions as we can. As always, it's always fun to stump the CMS employees, so if we don't have the answers, just make sure that you provide us with your email address or send me an email directly. Again, My name is patrick.hamilton, or my email address is patrick.hamilton@cms.hhs.gov, and I would be happy to follow up with you after the call. So, Kim, if you could unmute our first questioner.
Okay, this is a question from Candace.
Oh,
Candace,
I'm
your line is
sorry.
unmuted.
Yeah, okay, I'm sorry. I thought I had an audio problem. That's why I raised the hand.
Okay,
I'm fine
I'll
now.
put you back. Thank you.
Okay.
This next question is from last name Patel. I'll unmute your line. Patel, are you there? Hello, do you have a question? I'll mute that
All right,
line
next.
back. I'm sorry, are you there?
Now let's go to the next caller.
Okay. This is from Linda. Linda, are you there? Hello, Linda.
I have a question here.
Okay, let me try someone who's not on the computer. This one is from Aaron. Aaron, are you there?
Yes, this is actually Amy Mullins with the AASP, and this goes back to what you were talking about with the MACRA legislation. And we have heard from several other CMS presentations that the Comprehensive Primary Care Initiative is specifically not going to be in the alternative payment model because it is not an expanded model under CMMI. Can you clarify that?
Let me know.
Dr. Connors is going to weigh on this. Let me ask Kim, is Mimi Toomey on the line? And if so, could you unmute her phone? I'm not sure if she dialed in or not.
Okay, I will check and unmute her line. Thanks.
All right.
Okay, hello, this is Dr. Connors. The essential component to an APM
An
is
eligible APM.
eligible APM, which we haven't completely defined yet, is the financial risk. And the CPCI, as it is written now, does not meet the criteria for that financial risk. However, what I urge you to do is wait until the proposed rule is published, and then the AAFP can send their comments to CMS through the proposed rule. If you have members that are in that model now, you might want to speak with them now so you can gather all the information that you want CMS to hear from AAFP on this issue.
All right, thank you.
You're welcome. All right, Kim, let's take our next caller.
Okay, I have a call from Janie.
Yeah, this is Janine.
Your line is unmuted.
So I have a question around, we're a federally qualified health center, and I'm trying to understand how the MACRA and the MIPS and the PQRS applies to federally qualified health centers.
Again, I don't think that the FQHC portion of MACRA and how they would be applied with MIPS and APMs has been flushed out. More of that will come out probably when the proposed rule is released in the springtime. What I can tell you in terms of PQRS, PQRS applies to any physician payments that are billed to the Medicare Part B physician fee schedule. So as you know, FQHCs, rural health clinics, and a few other provider payment types do not submit claims to the Medicare physician fee schedule. Your clinic as an entity is not eligible for PQRS, which means you're not on the hook to receiving payment adjustments to your FQHC reimbursement for not submitting the quality codes. However, if you have individual EPs that happen to be working physically in your clinic and they are billing Medicare Part B physician fee schedule, they would have to report. But the clinic as an entity itself, while you are billing your FQHC services to Medicare, those are not subject to PQRS payment adjustments, nor are they subject to the meaningful use payment adjustments either. But again, if you have EPs that are billing outside of the F2HC billing mechanism to the fee schedule, they would be responsible.
Okay, thank you.
One other point that is a little off topic, but I think it's really important for F2HCs that happen to be on the line. That is through the TCPI program, the Transforming Clinical Practice Initiative program. One of the practice transformation networks is a group of federally qualified health centers, and they will be working with F2HCs to help ready the F2HCs for these new initiative programs. You can go on our CMMI website, look up the PTNs. If not, please send an email to me, Barbara, B-A-R-B-A-R-A, .Connors, C-O-N-N-O-R-S, @cms.hhs.gov, and I can send the information to you.
Okay, thank you.
All right, Kim, let's take our next call.
I'm going to unmute Edgar. Edgar, are you there? Okay, I'll mute him back. I'll try Julie. Julie, are you there? Julia?
Yes, I am. Thank you. I've heard from several sources that anesthesia providers in 2016 are required to report via registry. Could you address that?
I am not aware of any requirement that we specify any type of specialist or any type of provider for that matter, the means by which they have to report their quality data. Now, I think I have to go back and take a look at it. Now, that anesthesia might have been one of those specialty groups. I have
They only have one measure that's associated with them left as claims-based, but they still might have to do the cross-cutting measure. So I think that's where this kind of became an issue, is that they were down to one.
Correct. What I suggest you do is go on the American Society, the ASA website, and they're most up to date on recommending to anesthesiologists how to report the measures. We are going away from claims-based reporting, so
right,
this might. Okay, go on.
So, but I just want to clarify that they are not required to report via registry. They are not required to. They could do claims-based.
They're not required to.
Okay.
No.
Okay. That's what I'm hearing. I will check the ASA, though. Thank you very much. Anything else?
Thanks, Julia.
Okay.
All right, Kim, we're on our next question.
We'll try Nancy. Nancy, are you there? Nancy? Okay. We'll move that back.
No.
We'll try George. I'm sorry. We'll try George. Hello, George, are you there? Okay, we'll move back. We'll try Patrick. Patrick, are you there? Hello, Patrick.
Yes, I'm not sure which Patrick you mean, but I'll ask my question.
Okay.
One has been answered already. The other is perhaps still not answered, and that's back to the alternative payment model. Will MSSP track ones, which have no downside risk, qualify for the APM for providers, or has that not been determined yet?
Well, as I said before, we haven't completely identified, but a core component of an APM, which is written in statute, is that risk.
Okay.
Again, so I would keep my eyes out for the release of the rule.
Perfect. Thank you so much.
You're welcome.
Thank you, Patrick.
We do have one question here I'd like to address regarding EHR reporting for Medicare patients in the denominator of a measure, and the practice that is reporting does not have the full 9 measures. Patrick, do you want to go over that again?
Yeah, if they don't have the full 9 measures and you are reporting using your EHR system. And this goes back to the decision tree. I won't go back on the website. The requirement would be if you can't meet the 9 measures, 3 domain rule or requirement, then you must report the measures for which there's Medicare patient data. Now, as I mentioned earlier, your EHR is going to have information or patient data for all of your patients. It's not just the Medicare patient repository. So, and we allow you to capture or to submit data that pertains to all of your patients. However, if you're using your EHR and you can't meet that requirement, then you report the measures for which you do have Medicare patient data. Now, even if you can meet the 9-measure, 3-domain rule, you must make sure that you have at least 1 Medicare patient that's included. So that may be an issue if you have a low Medicare patient population. You just want to make sure that, and I believe that there are 64 quality measures that are included with the CQMs that can be reported for PQRS. Mm-hmm. So this becomes particularly an issue to pay attention to if you have a low Medicare patient population, because you really have to make sure that at least one of the measures that you choose from that big group at 64 would apply to at least one of your Medicare patients.
But they will not accept a 0 denominator.
Right. All right, Kim, can we get our next call?
Sure, and Mimi is on the line. I just want you to know. I'm
Okay.
going to unmute Annette. Annette, are you there?
My question is, we have nurse practitioners that are only hospital-based, and they basically are serving as first assists. So the measures are, and we're doing the general surgery measure group, so we would just select the 20 patients just as we would the surgeon, even though they're not the primary provider for that particular patient, in essence.
Are they billing Medicare under the surgeon's NPI or under their own NPI?
If for the first assist, they would bill under our tax ID number, but with their NPI number.
Okay.
But they're not doing any consultations in the hospital. It would just be billing for a first assist.
Under Medicare Part B?
Yes.
Okay, then they are required to participate in PQRS.
They are required?
Yes, and if they are only hospital-based and they're sending the bill with the 21 modifier, hospital-based?
21 if it's inpatient, 23 if it's emergency. The place of service.
It would be, I mean, basically there are employees. They're employed by the particular independent practice. It's billed as a first assist along with the doctor's fee. You know, they're helping. They're the second set of hands on procedures that they're allowed, that qualify for a first assist billing. So it would just be picking a case that they joined in on, and even though really most of the information is being provided by the provider, you would just pick 20 of those patients. Is that correct?
If they're billing under the TIN with their own NPI, and the TIN is not billing as a group, then yes, they would be required to report individually. However, if they're billing, if the modifier is inpatient modifier 21?
Inpatient's 21.
Inpatient's 21. Now, let me finish. I just want you to understand.
Okay.
Okay, so if they're billing only inpatient, then they would be exempt from the EMR, the EHR incentive program. However, if they're sending claims in to Medicare with their NPI as an outpatient, then they would also be subject to the EHR incentive program and the penalties at some point in time, not currently. But this is the time for them to start reporting and really getting into these programs, because they will be subject probably come 2018.
Okay. All right. Okay. Thank you.
Kim, I think we have time for one more.
Okay, I'll unmute Kathy. Kathy, are you there?
Yes, I am. Thank you. Yeah, I have a question about meaningful use, specifically Objective 10, public health reporting. So if a specialist does not give immunizations at all, and the state does not have syndromic surveillance reporting options available for physicians and offices, so they're really excluded from both of those, are they required to report to two specialist registries, or can they just report to one and then claim an exclusion for one of the other two? Just one.
Right.
Okay, that's what I thought.
It sounds like they would qualify for the exclusions for the first two, but if you read the measure for the third, and I can't because it's printed, it's just to one it's one specialty registry. That's the measure. So the objective says they have to meet two of the three measures. They can get exclusions for the first two, and then the measure is just one registry. So we don't bump it up because you do an exclusion for one of the other two. So it's just one specialty registry.
Great, that's what I thought. Thank you.
Okay, great. All right, we are at the top of the hour, so we're going to close out the call. Again, thank you for your patience, especially going through some of the technical difficulties that we had throughout the call. I do appreciate it. Just to let you know, we are going to be doing another webinar, the same webinar next Wednesday, same time actually, 11:30 to 1 o'clock Eastern Standard Time. We are going to go through the chat and go through all of the questions. Kim, I will ask you if you have the capability of sending me a file with all the chat functions or everything that happened in the chat. That would be very helpful. Also, again, if you have questions that were not answered during the call, you can send them to my attention at patrick.hamilton@cms.hhs.gov. So with that, we're going to bring the call to a close. Thank you, and we will be talking to you soon.